case, the patient was started on ibrutinib monotherapy and had an excellent response as measured by the symptoms that he had prior to starting treatment, the fatigue, as well as the palpable lymphadenopathy. Patients started on ibrutinib can often see rapid reduction in their bulky disease, both the lymphadenopathy or splenomegaly. Because of the reduction in these compartments, most patients will have a rise in their lymphocyte count when they're first started on treatment, and that should be noted because it does not represent disease progression, but instead movement of the lymphocytes, the atypical CLL lymphocytes, from the lymph nodes to the blood. But as in this case, that improves over time, and then often you'll also see improvements in the blood counts. Though patients can have rapid improvement in these methods, most patients started on ibrutinib or other BTK inhibitors as monotherapy will not achieve what is called a complete response, mostly because they have residual CLL in the bone marrow if the bone marrow were to be tested. However, in the case of ibrutinib and other BTK inhibitors, achievement of CR, even in a lower percentage of patients initially, does not necessarily by any means translate to the fact that the patient could not have long progression-free survival on the drug. It would not be standard in clinical practice, for example, to have to perform serial bone marrows to look for complete response, but the data that we derive from clinical trials can help in what to expect for these patients. In this case, the patient was found to have mild symptoms and started on therapy fairly quickly after the time of diagnosis. However, it is still guidelines, even with all these novel agents by IWCLL criteria, that patients only start treatment if they meet indications for therapy. These namely are disease-related symptoms that cannot be managed and affect quality of life significantly, either big or bulky lymphadenopathy or splenomegaly that is symptomatic to the patient or causing organ dysfunction, or if it is impacting their other blood counts due to marrow involvement. In this case, after workup, the patient had both anemia and borderline thrombocytopenia that would have met indications for treatment. But again, regardless of the novel agents, regardless of patients' risk factors, even patients with highest risk disease do not start treatment upon diagnosis unless they meet indications for therapy. When they do meet indications, in this case, the patient was started on ibrutinib Frontline as the result of randomized clinical trials. The standard of care for treatment with ibrutinib, with acalabrutinib, and with certain other targeted therapies is that they continue daily until either the patient has evidence of clinical progression or if they are not tolerating the drug. There are other targeted agents like venetoclax, which have been studied in a time-limited course in the Frontline. This includes venetoclax for a total of 12 months.